Good afternoon, everybody. I hope you've all enjoyed your lunch or food break, and welcome back to our symposium. Of course, I want to thank our presenters for their excellent presentations this morning. They were terrific, and I certainly learned from my colleagues as I expected to, and I hope you did too. We've received quite a few number of questions. We obviously can't answer all of them at this session. We hopefully will be able to do that at the breakout session as well. I've tried to pick some questions that are of general interest, that will be general interest to all of us and our audience, regardless of whether you have ET, PV, or MF. And the first question, and because this was a lunch break, was addressed to Dr. Hasselbalch. Does diet, including salts and sugars, affect inflammation? And should there be specific diets for MPNs, including, of course, vegetables, which everyone should eat, as your mothers told us? Dr.
I have no knowledge that we have data on this issue. My answer is we do not know. But of course, it is important to stress that the metabolic syndrome as an inflammatory syndrome and actually being more common in ET patients. If you look on this association, there may be an association between metabolic syndrome and MPNs, at least in the very early stage of the disease.
Okay, any panel contributions from the panel, please? Please.
I would like to add, so we do not know a lot about dietary interventions clinically, but there is some scientific data to suggest that high sugar diets could contribute to the pathogenesis of MPN. And this scientific data was published by Radek Skoda's group. As far as we know now, there's no clinical data to suggest that any dietary intervention has an effect on the MPN clone.
So another question that's very important, particularly in the days of COVID, is alcohol contraindicated, and is drinking alcohol too much? And that wasn't specified contraindicated. Of course, the definition of drinking too much is the patient who drinks one more than their doctor does. But other than that, I'm not aware of alcohol being contraindicated in reasonable amounts in the MPNs. Does anyone have any information regarding that?
Well, I think there is some general information that's recently come out that that alcohol use may be associated with the development of cancers. And this is sort of non-specific, cancers, but certainly we know that alcohol use is associated with the risk of breast cancer. There's nothing specific to look at the use of alcohol in myeloproliferative diseases, but it is cautionary that there appears to be an association of alcohol with the development of cancer in general.
Yes, and gastric cancer, of course. So several people have asked about CRISPR therapy, Ron, and particularly myelofibrosis. Could you tell us what CRISPR therapy is, and has it any use in myelofibrosis today? Dr. Hoffman?
CRISPR therapy?
Yeah.
Okay, so CRISPR therapy is a technology that's been developed and actually resulted in the awarding of a Nobel Prize, which leads to genetic modifications. So one could think that, for instance, let's say if there was a single driver mutation, one would think that one could eliminate, let's say, that driver mutation, whether it was calreticulin, MIPL, or JAK2V617F, and replace it with a wild type form of that gene, and then do a transplant and autograft, which has a much lower morbidity and mortality than is associated with allogeneic stem cell transplantation. I think our current understanding of the biology of myelofibrosis and myeloproliferative neoplasms is much more complex than it is present, than it was when that concept was first thought to be potentially useful for treating patients with MPNs. We now know that there are multiple clones that are present within these patients, not a single clone. And we saw graphic evidence of this recently, for instance, in patients who had multiple different clones with different types of P53 mutations. So I really, although I'd love to see this technology applied, I think it's going to be a long time before it's really relevant to the treatment of today's patients.
Any comments from the panel? Please feel free to add to the primary commenter.
Yeah, I mean, I guess my additional comment would be is, you need to do something more than fix the mutant cells, because the malignant cells have already proven their ability to outcompete the normal hematopoietic elements. And so if you took the MPN cells and you were to genetically make them more similar to normal, they would likely also lose that competitive advantage and would be overrun by whatever residual MPN cells would be there. So you'd really have to give some therapy, either completely myeloablation with a rescue that's perfect, meaning no residual unmodified cells, or you'd need to confer some sort of advantage to the genetically modified cells that would allow them to outcompete. So I think it's very interesting as an idea, but it hasn't even been tested in animals to really been shown that it is a therapeutic avenue for treatment. Not to say it can't be, it just, I think we're not quite there yet.
Well, I mean, based upon Joe's discussion of who's shown that there's multiple other myeloid gene mutations that are present, it's not as simple as we really thought, where we were only aware of driver mutations. So I think that this is a technology that is promising for genetic disorders, but is at least not very promising in being totally realistic in an acquired disorder that's associated with multiple genetic defects.
I thank you. So there is a question on next generation sequencing. I'll address this to Joe or Ron or Andy. Once these panels detect an abnormal allele, in addition to the driving mutation, do they ever go away? And what's the significance of their presence per se?
I mean,
Do they only go away with treatment, or do they never go away?
well, with a transplant, we would expect them to go away. Not every co-occurrent mutation has equal significance. Some of them seem to just be riding along and not causing a lot of trouble on their own, while as others seem to increase the chances of outcomes, like transformation or progression in other means. I think we have the ability to measure these things far in excess of our ability to understand them right now. But as time goes on, we may find some of the therapies in development have effects specifically on some of these co-occurrent mutations. There are a number of epigenetic modifiers that are in development, and they may have some selective advantage on clones that, or sort of subpopulations of the MPN that have more than one mutation. But so far, there's really no evidence one way or the other. And I think, as I said, we have more knowledge of what we can measure than we know what to do with that information.
Thank you. Question to Dr. Schafer and Dr. Hoffman about the V617F finding in the cells of the endothelial cells of the portal system. Do these tests ever show up in a patient who does not have a JAK2 mutation?
As far as I know, I mean, Ron can add to this. it's only the JAK2 mutation that's been identified, and it's really only been clearly demonstrated in the endothelial cells of the splanchnic vasculature, venous vasculature, which is very interesting. I mean, you have to remember that one of the questions is, how did they get there? Endothelial cells actually are a branch off from the most primitive hematopoietic stem cell, along with separately all the blood cell precursors. So it is related to the ultimate stem cell of blood cells. So it makes sense if the V617F mutation occurs at that early stage, that it could affect endothelial cells. But endothelial cells tend to only repopulate vessels, arteries, or veins that have been damaged to repopulate them. And whether that repopulation comes from adjacent endothelial cells that are still intact, or whether they come from circulating endothelial progenitors which settle into these damaged vessels, we just don't know that.
Have endothelial cells been examined in patients with arterial thromboses?
I'm not aware of that.
Ron?
I'm not aware. I'm similarly to Andy. I'm not aware of those studies.
Okay, thank you.
I don't think they've been. I mean, you have to have unfortunately, a post-mortem specimen to really look at this, at least the way we did it. And it would be interesting and intriguing to take a look at that in patients who have the JAK2V617F form of CHIP that Andy so depthly described, but we're hoping that those patients are going to continue to live so we won't have access to their specimens.
So a question addressed primarily to Hans and Dr. Andy Schafer. In view of the evidence of inflammation, is there enough reason to start and the emphasis on atherosclerosis and thrombotic events in arterial system, is there enough reason to start an anti-lipid agent when you first see a patient with an MPN?
I'll let Hans also contribute, because he knows more about this than I do, and he's really the pioneer in this field. I think that in addition to that, I think meticulous attention needs to be paid in MPN patients to all cardiovascular risk factors, any that can be reversed. We used to just sort of, as hematologists, not ignore them, but many hematologists have thought that the cardiovascular risk factor issues like smoking cessation and things of that sort, obesity, were in the domain of cardiovascular specialists. But I think most of us now pay real attention to this because they are an integral part of the morbidity and mortality of MPNs.
I can add to this saying that for sure smoking is a risk factor for MPNs, being demonstrated now in several studies. And the other thing is that I believe that in the future, similar to elevated blood sugar, for instance, elevated cholesterol, in the future, I think that, for instance, the JAK2 mutation will be the novel risk factor for cardiovascular diseases. And it has been shown in the general population, and we also know that the JAK2 mutation per se is a promoter of blood clots. So I think that we now open a new horizon where we have to acknowledge and recognize that the JAK2 mutation, as the TET2 mutation actually, are inflammatory mutations being likely put into prognostic scoring systems amongst cardiologists in the future. I really believe so. And that is also the reason why we go extramedullary and trying to screen high-risk cardiovascular patients for the JAK2 mutation, and also stroke patients. I think that it is the most important, or one of the very important area in the future to make research in how often a stroke patient actually harbor the JAK2 mutation, because otherwise they are undiagnosed, and we know that these MPNs are massively underdiagnosed.
So, but for the patients listening in, Hans, should they ask their hematologist if they should get a statin along? Well, let's say they're on interferon.
Well,
Is there enough evidence to suggest that or not?
yeah,
According to your, according to
we
your,
have, first of all, we have just recently published in British Journal of Hematology that smoking impairs the interferon response. And it makes a lot of sense when we look at smoking as a massive inflammatory stimulus, also to interferon signaling. And statins, they increase interferon signaling and thereby improve the interferon response. It has been known for years in hepatitis patients, and we have preliminary data, and we will make research in this area trying to figure out if a patient being treated with a statin actually has a better response to interferon than the patients not being treated with a statin. So I think that we should make research on the role of statins and the role of bisphosphonates in the treatment of MPNs, old inexpensive agents.
okay, but I'm going to pin you down because we have a lot of patients listening, several hundred.
I would like to add one thing though.
I'm not quite finished. Should they go to back to their hematologist and say, I want a statin because I heard Symposium, I heard Dr. Hasselbalch?
No. It is premature because, of course, we need the randomized study showing this.
Okay.
But in the real life, we cannot set up that study because every second patient above 60 is on a statin.
Okay, Dr. Ritchie, please.
I just wanted to add that I think that I want to underscore what Andy says. In the present, as we get studies sort of ongoing, looking at bisphosphonates and statins, which I agree are old medications that are not expensive, that are worth exploring, that I think it's important that we as hematologists spend time with our MPN patients really to assess cardiovascular risk factors and discuss with patients not only smoking cessation, but actually measuring their fasting cholesterol and helping together with their primary care and their cardiologist to make certain decisions. Younger patients with high cholesterol that I see, the cardiologist or the primary care is loath to put them on a statin, for example, even though their total cholesterol may be 316. So it's really important, I think, as hematologists to take an interest in this area and to help our patients with MPNs have the best cardiac outcome.
Dr. Silver, you are muted, I believe. Are you?
No, now he's muted.
Wasn't.
You're okay.
How is that?
You're okay.
A number of folks have, Dr. Scandura, a number of people have emailed in and said, essentially, how often should a gene panel be done under practical circumstances?
There really is no clear guidance on that. I think, a gene panel isn't a single thing. It can be a targeted sequencing or PCR panel looking at just the driver allelic frequency, or it can be very broad-based looking at hundreds of genes, even thousands. What the additive value of serial sampling of that is not proven at this time. I think many of us will look when there's a clinical change or if there's a therapy where we're expecting or worried about a beneficial or adverse response. So for instance, in interferon, I think many people will check at least a driver mutation periodically with the hope to see it go down, even though we don't exactly know what that means in the long term. We intuit that it is useful or beneficial. In people who seem to be changing their clinical presentation, we may look to see if it's increasing. and with, again, the intuitive but not proven suspicion that that may identify patients who are perhaps progressing. But the reality of it is there is not really a gold standard data set to associate one-to-one with repeated measures and specific outcomes. And so I think we don't have clear guidance, although many of us probably have our own practice patterns that do include periodic resampling.
So Dr. Abu-Zeinah, a very important question. Dr. Schafer pointed out that Dr. Barboui has emphasized that patients with PV and other myeloproliferative disorders have an increased thrombotic rate even when they have been, even before they have been diagnosed. And as you know, he presented very early this year at the European Hematology Association meeting a randomized trial between phlebotomy only in low-risk patients and those treated with interferon. Do you want to comment on some of these very early preliminary findings? I think this is of great interest to the listening audience and may have application to the other MPNs as well.
Yes, of course. So it's been known for several decades that patients who have polycythemia vera are at an increased risk of clotting, thrombosis, and thrombosis that can actually be fatal. Back in the 1950s, the studies had shown that the primary cause of mortality in PV is actually thrombosis. And back then, we didn't know so much about what are the risk factors that patients have to develop clots. And with time and experience, particularly with the results of the ECLAP study that was published in the New England Journal of Medicine 2003, the study have found that patients who are above the age of 65 or patients who have had a prior thrombotic history are the ones who are most likely to clot. However, those patients who are not above the age of 65 and never had a clot are still at an increased risk of clotting when comparing them to normal patients who don't have polycythemia vera. For that reason, it is important to think about low-risk PV patients as patients who are still at an increased risk of clotting compared to non-PV patients. And for that reason, one of the things that we institute for all patients, even low risk, is the treatment with aspirin. And of course, that was the conclusion of the ECLAP study, that treatment with aspirin over placebo significantly reduced cardiovascular events. The other thing that we do in terms of treating patients with low-risk PV is we have a goal for stringent hematocrit control. And stringent hematocrit control means controlling hematocrit to levels below 45%, which the CYTO-PV study has actually found to be, in a randomized controlled trial, has found to be optimal or ideal, and definitely better than maintaining hematocrit between 45 and 50. So for those reasons, those two interventions have been long used for patients with low-risk PV to prevent thrombosis. Nevertheless, we do have patients who are on this quote-unquote optimal strategy who still develop clots. And there's a lot of theories as to why that happens. And some of these theories that we're still exploring. And in that setting, it is important to recognize that in order for us to think about a risk-adapted approach to treating patients, we really have to think about a low-risk patient as somebody who we don't want to watch and wait until they develop a clot. We actually want to consider that if they're in fact at high risk of clotting despite optimal therapy and optimal control of their hematocrit, that we could offer potentially treatment that might have a disease-modifying role and might actually reduce the risk of clotting, even if it's very small. And that's where considering treatment like interferon is appropriate. And although we don't have any randomized clinical trials showing that interferon is beneficial over phlebotomy in this setting, we do have recent efforts, or there's a recent clinical trial conducted by Barboui and others in Italy, looking specifically at patients who are low risk and comparing or randomizing the patients to treatment with interferon versus treatment with standard of care, which is phlebotomy and aspirin. And the interim results of that study showed that after 1 year of treatment, patients who were on interferon, in this case it is Ropeg interferon, actually had better outcomes than patients treated with the standard of care phlebotomy and aspirin alone. And by better outcomes, I mean they had better hematocrit control, and they did not have disease progression, which was defined as getting a blood clot or even transforming to myelofibrosis. And so, that data has been presented by Dr. Barboui, and we look forward to seeing the results, the final analysis of that study.
Thank you. So the study was stopped after the first 100 patients were evaluated because the results were so strikingly in favor of the interferon treated group, although 150 patients were proposed to be included in the study. This is a very interesting question for the group, whoever wishes to answer it. Perhaps Hans, you might start out. If a person has an autoimmune reaction, parenthesis, hemolytic anemia to Pegasus interferon or associated with it, what would you do with regard to the treatment of the underlying myeloproliferative neoplasm, which is not specified with interferon? I presume it's polycythemia.
It depends on which autoimmune disease the patient suffers. We all know that autoimmune diseases may arise during interferon treatment, and when it occurs during treatment, I really hesitate to continue treatment. On the other hand, we also know that patients with MPNs are associated with rheumatic diseases, connective tissue diseases, for instance, psoriasis, and it is at least my personal experience that many of these patients, when being treated with interferon, psoriasis is a relative contraindication because then it worsens. But when at least in the COMBI trial, we can see that when we treat with interferon and ruxolitinib, these connective diseases, they indeed improve during this treatment. So, and that is also one of the reasons why I believe that the COMBI treatment is an encouraging treatment to be validated in other settings and in other studies, of course.
Which treatment?
A combination with interferon and ruxolitinib.
This is a really interesting question about autoimmune diseases. We do know that that interferon can unmask or trigger an autoimmune process, but beyond that, we don't know much. For example, does stopping the interferon after that cause a remission spontaneously in the autoimmune disorder? Does stopping the continuing the interferon, if need be, still allow the autoimmune process to be treated properly? So it really, the decision about stopping or not the interferon really is a risk-benefit balance for each patient, and you have to weigh the importance of Pegasus for the MPN, which may be really progressing, and it may be imperative to continue it, and how serious the autoimmune problem is.
So I would.
Andy, I'd like to make a comment. This is Ron. I know in our experience, we've treated a lot of patients with interferon here at Sinai, and unfortunately, some of the patients do develop autoimmune disorders. To the person, they resolve with the elimination of the interferon. And I think one of the things I'd be very concerned about is that an autoimmune disorder is a disorder that's associated with inflammation. And Hans and you have presented data about the inflammatory concept that inflammation contributes to thrombosis. So I would look at that as a potential risk factor. So I would really strongly encourage, we've had some people that have gotten quite sick with that. Admittedly, they're quite rare, but fortunately, they've all reversed themselves. So I'd give that some thought.
Yes,
further additional thought.
I would tend to agree with Ron. My own experience in a large number of patients treated with interferon, it is a very rare complication, but I've used that as a sign to discontinue interferon treatment for the reasons that he mentioned, because it is an inflammatory sign, and I've always thought that might predispose, rightly or wrongly, as he pointed out, we don't have the data, that it may be a risk for thrombosis. So I think it's a very interesting topic, as Andy Schafer mentioned. I would tend to use a word of caution to anybody who's developed any significant autoimmune phenomena as part of their illness to discuss this very carefully with their physician. I promise you this is not a loaded question. Two people have sent in this question, Dr. Scandura. It used to be thought that ruxolitinib causes general improvement in symptomatology because of its anti-cytokine effect. But now I understand there's a different explanation for weight gain. Could you explain that?
It's a loaded question.
I am not getting paid for asking that question.
Yeah, it's definitely loaded. I mean, I think that to put this in the context of, many drugs, when we start using them, they're used in patients without good treatment options. When ruxolitinib first was being studied, it was used in people who had quite advanced myelofibrosis, and many of those patients had a lot of symptoms, gigantic spleen, and some of them wore thin. And treatment with ruxolitinib, which can dramatically improve cytokine levels and symptoms and reduce spleen size, was associated with weight gain. And so that was something that was identified really in the earliest studies with ruxolitinib. And as happens with many drugs, as once they're approved and used more broadly and studied in other diseases, we start identifying things about the drugs that we didn't originally appreciate. And one of the things that we found was that many of our patients who were not underweight, who were not terribly symptomatic, for instance, being treated with for polycythemia vera as second or third line with ruxolitinib, were still gaining weight. And it just so happens my wife did her postdoctoral work with Jeff Friedman, who discovered leptin. And so I kind of had been around that signaling system enough to know that leptin, which is an important signaling system in the brain that kind of is part of our sense of satiety. When do we know we've eaten enough? And leptin is one of those primary signals. And it signals through JAK2, or predominantly through JAK2 in a specialized part of the brain. And so we looked at experiments in an animal model to demonstrate that ruxolitinib can interfere with post-eating leptin signaling and can interfere directly with leptin-directed leptin receptor signaling. And so, we can't do these studies in humans. It's a very, very tiny, it's only a cluster of small, a number of neurons in the brain. So it's very hard to image this. And obviously we can't cut people open to look at it directly. But the biology is similar, and I think it explains what many patients report, which is an increased appetite and more snacking behavior, eating between meals, that many of our patients experience with ruxolitinib. And I guess one of the reasons why we did the study is that I actually had patients coming to me with a lot of guilt, saying, oh, I'm eating like a pig, my spouse is on my case. And, I think it is helpful to be able to tell people before you even start the medication to expect that their appetite might increase and to have lower calorie snacks available. And if people are gaining weight early, they tend to continue to gain weight. And so this is where, an exercise program or dietary counseling can help mitigate the excess risk from an inflammation standpoint and from a cardiovascular standpoint that might be a result of the increased weight gain.
Thank you. Any comments from the panel? Thank you for that answer. So let's, you have a few transplant questions. The first is an interesting one. I was recently told that Pegasus interferes with stem cell transplantation. The transplant doctor stated that he does not support interferon usage prior to transplant. Per his comment, is there a lower survival rate with interferon? What is your experience? So I know that there is no literature that I'm aware of systematically collected about interferon in transplant in myelofibrosis. I think your doctor is referring to the old chronic myeloid leukemia literature in which interferon was thought prior to the days of imatinib, when interferon was used regularly for the treatment of that disorder. And it was thought that interferon just prior to transplantation was contraindicated. Studies clearly show that in CML, that if you stopped interferon 3 months prior to the transplant, there was no abnormal effect of the interferon. So one, there's no data regarding interferon with respect to its effect in myelofibrosis that I'm aware of. And two, I think that if one discontinued the interferon a couple of months prior to transplant, it would be satisfactory based on the CML experience. Anyone have any comment on that, Ron?
Well, I mean, we're only considering interferon use in those patients who have early forms of myelofibrosis, who are not candidates for the transplantation. So those patients, we're not transplanting any patients with polycythemia vera or essential thrombocythemia. The patients that we are transplanting have far advanced disease who are really not a candidate for interferon therapy. So I think that this association is a rare event, and I don't believe it's been systematically studied except for the experience that Dick mentioned, which is historical experience with the chronic myeloid leukemia patients prior to the identification of imatinib or tyrosine kinase inhibitor therapy for CML patients. So this should not be a contraindication for patients going to allogeneic stem cell transplantation.
So I should emphasize that point. We certainly agree that interferon is not useful in patients with advanced myelofibrosis. Wouldn't you agree, Hans?
Oh, certainly.
So that's
I agree.
That's universal. Okay, so Dr. Ritchie, you're involved in a lot of transplantation with your patients with leukemia. If we use, the question is, if we use a less intensive regimen, would more patients with myelofibrosis be eligible using a less intensive preparative regimen? And so Ron said 70 years and younger, but at Cornell, we've transplanted patients up to 80, correct?
We have, although those are very special patients. So I think Ron also mentioned that looking at the fitness of that patient or the comorbidities of that patient are incredibly important, especially when you're looking at someone over 70, as to whether we think they would be able to withstand the rigors of transplant. The invention of a less intensive conditioning was really meant to extend the age of transplant well beyond 40, which was really the original ceiling. And it has allowed for us to include many older patients in allogeneic transplant that would not have been eligible to do that previously. So it's really expanded the group for which we can transplant, for whom we can transplant. But that being said, looking at the fitness of the patient is incredibly important. And if you're 60 years old with diabetes and hypertension and coronary artery disease and obesity and other problems, you may be less fit than a 72-year-old with virtually no comorbidities who's playing tennis, a set of tennis every single day. So, age is one measure really of fitness. And in the transplant literature, actually it's age all by itself was not a contraindication to transplant.
Dr. Hoffman, do you agree with that? How, when you say 70, do you extend?
Well, I mean, I think that, there's age and there's age. people are, there are some people who are 50 who unfortunately look like they're 80, and there are others who are 80 who look like they're 50. So I think the paper that I presented talked the SOROR index, which is a objective measurement of comorbidities, is an important determinant in determining who is a candidate for transplantation. You know, as I presented in my talk, it is most of the patients, virtually all of the patients that we see now have donors for transplantation right now. And then that is really the only curative treatment that we have for patients who have intermediate or high grade or high risk myelofibrosis. So we really try to encourage the patients. I think one of the limitations is really the risk that the patient is willing to encounter. And also we're very carefully explained to them that the 6 months after transplantation is a really a true stress test. It's not an innocuous intervention. So we try and be extremely realistic to these people to understand what is going to really be involved. We're very reluctant to transplant patients, you know, up to in the high 70s, up to age 80. I'm sure there are exceptions to that, but I think that for the usual patient, I think that it's for the routine patient, that has to be in a very exceptional situation.
I agree. And that's a patient with really no comorbidities who is, although they may be 76 or 77, they really are closer to resembling someone who's 55 or 56. And those patients do exist. As you know, Ron said, it's just a number. But I think that transplant has to be very carefully considered. There's a lot of things that go into transplant, not the least of which is, you know, the time that you're going to spend feeling ill and the need for a caregiver who is 100% devoted to your recovery at the early points in the transplant. This is not something that you can do without someone who can assist you.
I would strongly agree with that. Very few of us are Dick Silvers, so we have to sort of.
I never had a transplant.
No, I know, but you're sort of very robust. And, you know, so I think that we have to really sort of assess people individually, and I think Ellen's approach is really the right approach. I liken the first 6 months of during the transplant and the post-transplant time period is really a war, and the patients need to get into appropriate mindset and physical condition to withstand the rigors of that war. It's tough.
It's worse than COVID. So a very important question a number of people have asked, and our time is pretty much coming to a close. I want to answer these two questions. Is interferon alpha 2A different than 2B? And then say, how about this new rofuron? I don't respond to interferon alpha 2A, well, I respond to rofuron. And similar. It's very important. I'm sure Hans, who has used as much interferon as I or more, would agree there is no qualitative difference between the interferons. We say this over and over. It's only
from our DALIA trial, we can conclude that peg-intron, dropout rates on peg-intron were higher than on Pegasus. That is one message. And the other one that I would like to say is that at least I have seen patients not tolerating Pegasus and then tolerating peg-intron and vice versa. So it is not so that if you do not tolerate one interferon formulation, you do not tolerate interferon at all.
No, I agree with that completely, but you won't, if you don't respond to an interferon, changing the type of interferon will not make you respond or not. It's whether you tolerate it will differ, but not your qualitative ability to respond. In other words,
no, I do not. The quality of response is adequate.
Okay. Hans, the question that I want to ask you, you have been the leader in using combination therapy with ruxolitinib. And you've also, along with us at Cornell and MD Anderson and the Sinai, we've all published papers on the side effects of ruxolitinib with respect to infections, secondary cancers, lymphomas, et cetera. How do you reconcile the benefits of, say, 5 years of Rux with interferon versus the adverse events associated with the use of that drug, which have been talked about by Ellen and Ghaith and Dr. Schafer and Dr. Hoffman?
I do not favor monotherapy of PV patients with interferon. That is certainly not my favorite treatment choice. Instead, I think that it is important to start early with interferon alpha, and the earlier you treat with interferon alpha, the shorter is the time period that you need to treat to achieve major molecular remissions. We heard before that actually I think that it is important to monitor serially JAK2 allele burden during interferon therapy. Not only in the research setting, we have shown by data-driven analysis that the earlier you treat, the shorter is the treatment period needed. And that makes a lot of sense, since when the tumor burden is huge, you have to treat longer, and it is much more difficult to overcome the tumor burden. So when you treat early, you may have a chance to induce minimal residual disease in the patients.
Okay, well, that was not quite what the question I was asking, but our time is up. It's 1:32, and we do have to reconvene at, it's 1:32 at New York time, and we will convene at 2 p.m. again, Eastern Standard Time for the breakout sessions. Thank everybody. Thank our panel again. Thank our audience. Thank Andrew, Alex, David Booley, Mara, and Barbara Rosenstein, our staff members here in the office. Thank you, everybody.